I think my screen is visible.
Yes,
Hello.
Vivek sir, thank you.
Yeah. So on the World Mental Health Day, I welcome you. Sorry, for the talk on stimulating the brain to heal the mind, and why these topics are important is of old in nature. But first, we have to understand that why, how does the brain work? And if you just put it in a very simple format, your brain is an orchestra. It's just like a musical band where a network of 86 billion neurons conducting the music of our thoughts, emotions, and actions. And when this symphony gets out of the tune, a behavioral, psychiatric, and neurological condition arises. So, for example, in our frontal lobe, when it is impaired, it is more of a depression and anxiety. In our middle of the brain, called the thalamus, it's the OCD, and where it's global, it is called the seizures. So the challenge with the pharmacotherapy is they have limitations. For example, if we take 30 to 40% people with depression falls under treatment resistant or refractory. Same goes for the post-stroke rehabilitation. About 80% of the patient live with a disability. Limited efficacy and side effects can we hinder the adherence to the treatment in neurological rehabilitation. Now, what is the brain plasticity, or what, if you have heard before the term very commonly used, it's the neuroplasticity. So the brain is not static, it constantly changes, adapts. The ability of this change is called the neuroplasticity. Non-invasive brain stimulation harness for the therapeutic purposes. In short, we can take the advantages of these plastic changes where our ability to modulate, we can modulate our brain using different brain stimulation methods. If we say why, what is the brain looks like, and more often, like we talk about we talk about different brain regions. There are 50 different regions called the Broadband. We can precisely target them using the 1020 system. It's like a brain atlas, like a Google Maps for the road, and we can able to modulate those networks either excitatory or inhibitory in nature. So as I said that why do we want to stimulate or inhibit? So if we say this is our resting state brain on the top and the down, if we walk, there are certain activation happen in the motor cortex. When we are seeing any object, there is activation of the back of our brain. We talk about, I will show you pointer here. When we are hearing, we see our left side started to stimulate thinking, frontal lobe. So there are different brain regions or roles, different understand react like processes. While modulating those, we can able to guide them that how they should be optimally functioning. When we talk about the early brain stimulation, it is not a new method. In early 1800s, this type of method where an electric fish or eel or a torpedo, of, like if you say this put into the water and this touch on the patient forehead. Now, that's the first use of bioelectricity and electrotherapy in in medicine. But in research, it started in late 1800s and 1900s, where Giovanni Aldini in 1803 used vaulting devices to stimulate the patient and the corpses. At that time, Rudolf Erland in 1970 applied the electrotherapy to the scalp to treat mental illness. And this is the first time uh, electricity is being used. And the first paper it takes of Hugo Demison, the use of electricity in medicine, published in German, and that is their medicine. And from there on, there are progression which happens over there. 1996, a novel demonstrated electromagnetic stimulation uh, body. 1910, Salvinus demonstrates retina stimulation because of the magnetophosphorin. So this is the size of the coils before, if you see, and how we have evolved. In 1980s, the transcranial electrical stimulation was first demonstrated, and the idea of TMS goes back to the early 1900s, as we saw. 1985, Tony Barker and colleagues produced the first TMS. If you can see the TMS, it's the shape size more or less looks the same even now. And in 1984, David Cohen, and 1988, Shuonego have developed the idea of realization of the figure of eight. So this is Tony Barker with his circular coil, and then the figure of eight coil came into picture. And this is the modern figure of eight coil, which is placed on the scalp, again using the 10-20 system, or if there is there is a neural navigation is present, you can use the neural navigation and place the coil on the very specific points. So TMS is a transcranial magnetic stimulation, is an established non-invasive, non-convulsive, there is no seizure involved neuromodulation technique, initially developed in the mid-1980s as a tool to study human neurophysiology. Later, it turned out that there are benefit or therapeutic uses in these modalities. The FDA approved the treatment for depression, OCD, chronic pain, and can be used effectively for other neuropsychiatric conditions like post-stroke rehabilitation, Parkinson's disease, psychosis, and there are many more like fibromyalgia. So RTMS is a painless, non-invasive, requires no anesthesia or sedation as compared to the electroconvulsive therapy, the shock therapy, where it do require it. So the neuromodulation journey at the Buddhi Clinic started 2017, 2018, where then during the training at Ramam Healthcare Campus in Haifa, I worked under Professor Bellmaker and Health Clade, and we realized that there are a combination of when we use the TMS with multiple integrated approach, it have a positive impact. But we have to understand that what is exactly the TMS doing to the brain. So TMS uses electromagnetic induction to generate transient, localized electric fields in the brain cortex. RTMS use patterns, multiple TMS pulses can be used in a chosen brain area. So they typically ranges from 1 hertz. There is 0.5 in very few cases, but 1 hertz to 20 hertz, and there is a theta burst stimulation can go up to 50 hertz. When the TMS sessions adjunct with the cognitive behavioral therapy, we can prime the brain to more responsive and reduction of the symptoms more efficiently. So this is an example, infographic that when we apply the head, the magnetic pulse is delivered to the brain. It based on the Faraday's principle, the basic physics principle behind it, reducing fluctuating magnetic field induces current in underlying cortex. That current can permit focal manipulation of the circuits. So these are the different frequencies, as we say that 10 hertz, a typical this 10 hertz is very excitatory in nature. So as goes for the intermittent theta burst is excitatory in nature. When we talk about CTBS, 1 hertz, single pulse TMS, they all are inhibitory in nature. Single pulse also have a role in the diagnostics, like the peripheral neuropathies can be diagnosed very much with the single pulse TMS, and this is what the pulse generated into the brain. So there is a biological proof, like holder, be it patient, caregiver, or treating team, they always ask, like, how does this work? And we can see the serial MRIs or fMRI when we take, there is a regional blood flow. So over the top, the red one is the higher frequency when we use 20 hertz. And we see in the frontal lobe, as we go along into the sessions, there is more and more firing is being seen, that the brain area is getting activated. On the same, when we use the low frequency, we see that there is the area which is getting diminished, the blue dot. So we start here, and then we see that the areas, the activation is diminished. Well, decreased cerebral blood flow is also useful in treatment of depression, addiction, and cases of OCD. So, if we just talk about the mood disorder, several studies demonstrated that repetitive transcranial magnetic stimulation is an efficacious treatment for treatment-resistant depression. And as we said, the 2008 FDA approved it for the use under Class 2 restrictions, special control that it can't be used, it should be used under supervision. And then comes the adjunct studies that when we combine the RTMS and the psychotherapy, it results in 66% response rate and 56% remission rate, which is much higher than compared to the previous randomized controlled trials where they only use the TMS. So now we have the evidence that combining the psychotherapy with TMS does help. And evidence also suggests that major depressive disorder is the most commonly associated with hyperexcitability. If you just look, there is no depression, there is hyper. And here, if we look, there is a left prefrontal cortex and hyperexcitability over the right cortex. So there are biological changes which do happen in the brain in order to produce the symptoms like depression. So, so this is a tip. So that was the example of one of the person when during training have undergoing the TMS for depression, and that's how the coil is being placed, and you see that there was no apparent comfort in the condition. Now, anxiety disorder like OCD, post-traumatic stress disorder, and panic disorder, there are healthy controls. There is no activation if we see. In OCD, again, there is no activation. But when we see the schizophrenia, there is activation, schizophrenia plus OCD. Again, there are activation, hyperactivation is being seen on the temporal lobes. While now, if we would have thought about the OCD, like when we take the different targets like dorsolateral prefrontal cortex, orbitofrontal cortex, right dorsolateral, and subliminary motor area, and we see if this is a zero line and if the blue spade is on this side, diamond is on your right side, it means it is efficacious. If side it is not efficacious. And in all the studies, no matter which area you target, they show a greater efficacy, especially if we look the supplementary motor cortex, there the efficacy is the largest on like, ranging from 0 to 2.5 effect size. So definitely SMA is the better targeting area for OCD. And the TMS can also be used in cases of Alzheimer's disease. It's a randomized control that the stimulation to precuneus, which is back of our head, can able to bring out the changes which are quite impressive if you compare the data with the monoclonal antibodies, what in US everyone talks about. Okay, so if we move on to the next TDCS, the fine-tuning the brain with a circuit with electricity, well, the transient direct current stimulation, though the word current is there, it is basically a very gentle electrical stimulus. TDCS uses weak electrical currents to modulate the brain activity. If you see in the photograph, an electrode is being placed, machine is being kept, and a mild 1 to 2 milliamps of field is being passed. So TDCS also can be used to treat depression, anxiety, mild cognitive disorder, speech and motor symptoms like in multiple sclerosis, post-stroke, Parkinson's, etc. One of the advantages of the TDCS, it can also go to the bedside at home use because the machine is so small, it can travel. TDCS is a painless, non-invasive, as well as well tolerable across the lifespan. There is only like, mild end bite kind of sensation that will last only for 1 or 2 minutes. But we do scan for people. There is an inclusion criteria for both TDCS and TMS that who is the right fit for these modalities. Not everyone are fit candidates, but more or less, when there are no history of seizures, most of the people are able to tolerate it very well. So if we just talk about the TDCS, its neurons are more less likely to fire, unlike TMS. It does not trigger any action potential, more charge over time, and it produces a longer lasting effect. That's one of the advantages of TDCS. And in this infographic, we see that there is one anode is being placed over the right side, and then the cathode on the anode is on the left, and it is on the right side, and the current goes from one electrode to another, and that's what stimulates or inhibits the areas, also known as the depolarizing and hyperpolarizing. They can use multiple types, like TDCS. It is transient direct current stimulation. It has a fixed intensity. When you talk about the TRNS, which is a transcranial random noise stimulation, there is no fixed variant, but it is can be configured. And TSCS, transcranial alternate current stimulation, which have the alternate patterns of frequency. Again, looking at the brain structure, where we put the positive electrode, we can see there is activation happening on those particular areas, whereas when we place the cathode, there is a hypoactivation. So definitely we do have a proof to that these TDCS methods bringing out the change in the brain. Same thing what we have already discussed. And if you look, this is an example that one of the child is getting the TDCS while doing the psychotherapeutic intervention. For example, a clinical psychologist with a kid who is hyperactive but unable to sit at one place, but we can training the brain while he is doing the exercise. But there is a very deep protocol workflow which goes for each children. Like if we take an example of ADHD, we have to find whether it is an inattentive type, predominantly hyperactive, or it's combined. There is a so we can choose the different points for different behavioral variants, and it is in that way it is very personalized when we talk about the treatment with the non-invasive brain stimulation methods. Now, because the science is so advanced, obviously we just signals and to the bold signal responses which can find how the brain is firing, and we can plot the over the brain. The bold signal then detect where the signal is coming from. But how we can able to change these networks? If we talk the TABNS, which is the body's brain connection, TABNS is the body stress response. Interior, it stimulates the interior. It's a medulla. It the heart, blood, and your upper GI. This particular response, uh, the battery is being placed here. So we can to outside. It's found to be very effective in of epilepsy, for headache, insomnia. Usually, medical sessions will again know that you should do the differences in the brain activities, what we can look for. And there is a very recent paper published is that VNS is being application being driven in stimulate the nerve non-invasively, creating the opportunity to novel use of this in healthy population. Now, when we talk about the healthy population, we also talk about the gut-brain axis, which is directly can be controlled using the vagus nerve, chronic inflammation, and other techniques. Moving on to the next. neurofeedback, near training the brain to train itself? Well, a quantitative EEG guided neurofeedback therapy enhances our brain function by practice. So there is no modulation in this. There is no current or magnetic field being induced. But once we monitor our brain signals on the screen, we can alter our behavior. For example, if I have to look at work on a task or look at an object, there is no proof that I am looking at the object. I might be thinking something else. But when we plug feedback, we can able to tell that are you looking function at or working at the task or you are thinking something else. Now, bringing your attention, volunteering to the task, we are training our brain, and that's why uh, this neurofeedback therapy has been shown improvement in treatment of disorders like ADHD, anxiety, depression, epilepsy. There are multiple things what can be used, such as drug addiction, schizophrenia, and others. Well, to the clinic, we do have the magnetic functional stimulation. It's modulating the nerve-brain junction. Just like the TMS, the FMS is for the body. The FMS uses high-intensity magnetic pulses to enhance rehabilitation processes and relieve the pain. FMS is also known previously as a peripheral magnetic stimulation, used to treat the spinal cord injuries, frozen shoulder pain, upper and lower back pain, musculoskeletal symptoms. And recently, the research is highly focused on the fibromyalgia, neuropathies, and in some cases of neurogenic urinary incontinence from injury or by the nerve damage. It's being we found it to be very, very useful. So there is evidence, there is no success stories around. There are lots of data published, be TDCS for neurocognitive disorder, to TMS for the depression. We talk about TDCS again for prefrontal and cognitive impairment, stroke rehabilitation. So there's lots of research which has been published around the world, which is bringing the new use of modalities of the same, like different protocols to enhance the outcomes. So before we look for, there are the new terminologies called neuroergonomics, where it is an emerging field, investigates the human brain in a relation to behavioral performance in natural environment, which means using the TABNS, TDCS, we can enhance our day-to-day functioning. Now, this research at currently it is at research level, understanding the neural mechanism underlying the perception, cognitive, and motor functioning. For example, in sports, the TDCS has been used in learning patterns. The TDCS has been used. So, of course, it's a developing field, and the more we understand about our brain, the more we can stimulate and more we can heal faster. But before I close, there is a new era of non-invasive brain stimulation is coming. By understanding the brain and mind disorders, we can target the specific brain regions, enhance the recovery, and even in intractable cases where the medicines are not being used or helpful. Recovery is multifold when adjunct with integrative therapy approaches composed of physics, clinical psychology, physiotherapy, holistic care, and optimized pharmacotherapy. So it's not just doing a randomized controlled trial that you take TMS and one person takes the drugs and which person improves better, but it's a combination of approach which brings back better outcome for the people. So in conclusion, non-invasive brain stimulation methods are valuable in research and have potential therapeutic application in cognitive neuroscience, neurophysiology, psychiatry, and neurology. These NIBS techniques widely used in studying physiology and CNS vitals, identifying functional role of specific brain structures, and more recently in exploring the large-scale neural network dynamics. And NIBS should be used with ethical and within the control under the supervision with precision focus. Because if you say, if you remember the Broadman areas, there is 1 centimeter, you are off the target, you are stimulating the whole different brain region. So before I close, I would like to bring the attention that the first war, as we say, is a social media war, and the recent research do suggest that the civilian soldiers and those consuming the war through the social media can develop the typical psychological profile of a trauma. And studies also have shown that the consumers of the war via television, social media, and other forms of media can be just as impacted as actual individuals with the conflict. So keeping in this turbulent time, keeping ourselves more relaxed, distance from social media is the best way to avoid the trauma profile, but a person can impact and the mental health concern, especially the anxiety and panic. With that, thank you for your attention. I'll be happy to take any questions if there are any. Okay, fine. If there are no questions, let's close the session.